So I'll actually start with a quick introduction and a joke as I go into these slides here. So my background is I'm an economist and a physician. Let's see here. No, that didn't work. Where's the F5?
It's one right there.
So I'm an economist and a physician. I spend most of my time doing research on healthcare productivity. One of the areas that I look at is what happens to patients who are hospitalized during cardiology conferences. And so we find that patients who are hospitalized during these meetings actually have better outcomes. So I'll actually spend a minute to start with a joke, if that's okay. Audience participation would be welcome. So how do you hide a dollar bill from an internist? How do you hide a dollar bill from an internist? You hide it underneath the bandage. Internists don't like to unroof bandages and take a look. Jay would know this now. How do you hide a dollar bill from an orthopedic surgeon? Okay, you put it in the medical record, you put it in a textbook, anything that confers the desire to acquire knowledge. I hope there's no orthopedic surgeons. And then how do you hide a dollar bill from a cardiologist? You can't hide a dollar bill from a cardiologist. All right, so that has absolutely nothing to do with the wider public health value of hepatitis C, but I hope that at least prime you to listen thoughtfully about what I'd like to spend the next 5 or 6 minutes telling you about. So I think Darius did a terrific job laying out what are some of the financing issues related to cures for hepatitis C, particularly as we see patients transition from private insurance into Medicare. But I want to take a step back to think about what are the wider public health implications for hepatitis C. So think about what the cures for hepatitis C do. They cure the disease. So we're talking about the potential for 90% upwards of the hepatitis C population to no longer have the disease. And so if you think about, well, what is the value that creates to the individual? What is the value that creates to society? It's easy, I think, to say, oh, I know the answer. The value to the individual is that this person will no longer have chronic liver disease, no longer have end-stage liver disease, will no longer require a liver transplant. I think that's a pretty straightforward extension of the thinking of what is the private value to an individual of giving them a cure. You could take a step further and say, well, this is an infectious disease. So that means that if one person gets cured, that lowers the likelihood that other people in society will get infected. And you can imagine how that has some value to society. But now all of a sudden you're starting to think about value that drugs create, in this particular case, a cure for an infectious disease. You're starting to think about the value that these drugs create in a way that's not just simply inside the box. And what I'd like to describe to you is another way to think about it that I think is extremely impactful, but it touches on this broader issue of how do we measure value in healthcare, and actually just why is that important? Right? Why is it important to measure the value of a drug correctly? The reason it's important is the reason it's important in everything you do in life. When you go to a car dealership, when you buy a suit, when you buy a soda from the store, you think to yourself, well, what is the value of this to me? And if my willingness to pay for that product exceeds that, then I will buy it. Exceeds the price, and I will buy it. And so it's always important to have a notion of value. Now, take a 30,000-foot view and you're a large health plan or you're a federal government, you need to understand the value that different things provide. So Medicare, in conjunction with the federal government, has to understand what is the value that a particular health care product provides, because the dollars that would go there could instead go to schools, could go to other public infrastructure. And so it's not just important to say, well, I realize that hepatitis C drugs are valuable. That's not enough. You actually need to be able to measure the dollar value of that. And that's why it's important. And the point I'd like to make today is that we hear a lot of controversy about the pricing of hepatitis C drugs. And there's no doubt, I think, in the clinical community that the drugs in the last few years represent medical breakthroughs. I think that's a well regarded view. But the question that always comes up is, well, what is the price, and do they offer quote-unquote good value? And so implicit in that discussion is some notion of, well, we think we know what the value is. And what I would argue now is that I don't think we have a good, kind of a solid understanding on that value, and we need to be more creative in thinking about what these drugs offer. So why is this particularly important in hepatitis C? Well, I think Darius laid it out very nicely. These drugs are expensive. So these drugs they are not cheap. They're very expensive. And they have large budget impacts because the HCV population is quite large, right? And so for a lot of reasons, for these reasons in particular, from the financial considerations, it's really critical to understand what is the value that these drugs provide. And so I kind of mentioned the straightforward analysis of value is the fact that you can prevent someone from dying from liver disease if you cure them early enough. That's, I think, everybody would understand. The second extension of that value argument goes that this is an infectious disease, and if you cure someone, you reduce infectivity in the whole population, and so there's value to that. So now all of a sudden you're thinking, well, if the value of a cure for hepatitis C was X dollars in my mind, adding that second component, which is to say that we lower the risk of infection, that's going to add something to that X dollars. But there's more to that than that. And that is what we published in the AJMC, and we have several co-authors in this room. And by the way, thank you, Ryan, and thank you, colleagues from the AJMC, for putting this together. So here's what I want to tell you. Imagine the following. We have two types of patients who have liver disease. So the first type is a group of patients who have liver disease from hepatitis C. It leads to cirrhosis in some part of the population over time. They end up getting end-stage liver disease, and then they ultimately require transplant if they don't die from the liver disease. So that's one population of patients. The second population of patients is actually a really large population, and that's a population of patients who have liver disease from causes other than hepatitis C. So you can get liver disease from long-standing alcohol abuse. You can get liver disease from hereditary diseases. You can get liver disease from toxicity, for example, from Tylenol is a well-known toxicity. Another major cause of obesity now, and it's increasing in prevalence, is obesity related to obesity. So it's called fatty liver disease. So there's this whole world of liver disease that has actually nothing to do with hepatitis C. And why do I mention that? Well, I mention that because these two things are actually linked. And here's the linkage. The linkage is the following, that the number one cause for liver transplant in the United States is hepatitis C. So what will happen when we cure hepatitis C? If we now look forward 20 years, and let's say hepatitis C prevalence has been reduced dramatically, what is going to happen to all of those livers that used to go to patients with hepatitis C? Where are those livers now going to go? Right? So 20 years from now, once we substantially reduce the prevalence of hepatitis C, the demand for liver transplants in that population is going to go down dramatically. And where are those livers going to go? Those livers are going to go to patients with alcoholic liver disease, fatty liver disease, hereditary hemochromatosis, other forms of liver disease. And so what's really interesting here is when we think about healthcare, we kind of think about it in a silo. So if there's a new medication that treats heart failure or a new medication that treats multiple myeloma, we think to ourselves, well, those patients have benefited. Well, here's a really unique example in which treating patients with hepatitis C and curing them of the disease actually doesn't just treat those patients themselves. It has these spillovers to patients with other forms of liver disease. And so diseases are linked in this really unique way because there's a scarce resource here. And that scarce resource is liver transplants. So if we had infinite liver transplants, what I'm saying wouldn't make sense. It wouldn't hold any weight. But we actually don't have infinite liver transplants. And for those of you who know anybody who's had liver disease who received a transplant or was on a transplant list, people die on these lists. I mean, that's the nature of the allocations today. And so this schematic basically illustrates that point. At the top left, you have patients with hepatitis C. Currently, they're getting the majority of the livers. Those are the orange L's. At the bottom left of the screen, you see patients who have other forms of liver disease. They are getting the minority of the livers. These are in green. And ultimately, the liver transplantation is going to be the cure for these patients until now. So what happens when you introduce a cure for hepatitis C? Well, the schematic changes. So now look at the top left. You no longer have all these livers being transplanted into patients with hepatitis C. Those livers instead can be allocated to patients who have other forms of liver disease. So that's why the green L's at the bottom have increased. And so what does that mean for society? Well, let me give you some numbers. So over the next 20 years, and this is what we published in the AJMC, and if anybody has any medical contraindications to Ambien, feel free to read through the methods section. That will do the trick. But again, the idea here is actually quite simple, even though the methods required to get there are more complex. And I'll just say a word about it. We used economic, epidemiologic modeling to study disease trends in liver disease, to use liver transplant allocation models. We combined all that together to try to understand over the next 20 years, what is the answer to the following question? Over the next 20 years, if we are able to systematically screen for HCV and treat HCV with the new drugs that exist today, what would be the impact to society in terms of livers transplanted to patients without hepatitis C? And so here are some numbers. So over the next 20 years, if we do better, and the details I won't describe, but if we do better at screening patients with hepatitis C systematically and then treating them once we identify whether or not they have HCV, about 10,500 transplants would be spared. 10,500 liver transplants would be spared from going into patients with hepatitis C in the next 20 years because we've cured them of the disease and prevented them from actually having to get transplanted. So those 10,500 livers, where would they go? The vast majority, about 7,300, would actually go to patients with liver disease from fatty liver, alcohol, other forms of liver disease. And the remaining 3,000 would go to patients who have hepatitis C, who were not able to be treated by the drug or who didn't get screened. So the summary here, and this actually is my last slide, the summary here and the take-home is the following, is that we need to get better about understanding value. So here is probably one of the, I operate in this world of health policy, and perhaps the most widely discussed drugs in the last 3 to 4 years are the drugs to treat hepatitis C, and there's been constant questions raised about their value, and I think rightly so. These are expensive drugs, and so you have to be able to justify what the value is to society. And the point that we want to make here is that if you view value in this really siloed way, you leave a lot on the table. And what I mean by you leave a lot on the table, you don't incentivize innovations that actually deliver value. And so the next cure, so the cure for hepatitis B or hepatitis A, that cure may not be developed. And the numbers here are quite large. So in just this example here, if we're able to systematically screen and treat patients with hepatitis C, we're talking about 10,500 livers that would be spared for transplantation into these patients over the next 20 years, 70% of which could actually go to patients who don't have hepatitis C. And so this is a really unique disease spillover. And this kind of logic doesn't just stop here. If we do a better job at treating, let's say, diabetes, let's say we have a cure for diabetes, that's obviously going to be hugely beneficial to society, both clinically and financially. But if you cure diabetes, then patients with diabetes who require kidney transplants today will no longer require those kidney transplants. Where will those kidney transplants go? Well, they could be transplanted into patients who have end-stage kidney disease from chronic hypertension, who have end-stage kidney disease from diseases of childhood or other acquired kidney diseases. So this kind of logic extends beyond just hepatitis C. But the broader point is that it really illustrates the importance of being thoughtful about measuring value when you're talking about new technologies. Thanks.